Good afternoon, everybody. Welcome to this program where I'll be talking about McGaw Geriatric Fellowship Program and basically giving you a progress report on the things that we have done over the last few years. I'm Dr. June McKoy. I'm the program director for the fellowship and have been the program director since 2013. We are a dynamic program, and I really want you to close your laptops, stop what you're doing, and pay special attention to what we have done in the last few years to advance geriatric medicine in the United States. So the geriatric medicine program started in 1989. And before I go into any depth about how that program came to inception, I'd like to introduce you to the leadership. Our division is led by Dr. Lee Lindquist, who is a well-known geriatrician on the national stage. Dr. Lindquist holds a master's in public health, an MBA from McKoy School of Management, and got her MD degree from the Feinberg School of Medicine here at Northwestern. Dr. Lindquist is fully funded, actually has 3 McKoy grants and 2 R01 grants and 2 R21 grants. And her work is really focused on helping older adults to age in place and helping them to transition to care environments and actually thrive in those environments. Her work on planning your lifespan is actually quite well known, and she has been asked to speak as far as Hawaii, certainly in Canada, about the work that she's doing. So we're very fortunate, and it's a really nice segue into how our program, when our program started and what our program has done, because Dr. Lindquist is a product of our program. She went to her medical school, shadowed with our then division chief of geriatrics, and took on a patient panel early after her internal medicine residency ended. And she has grown up through the program, and we're extraordinarily proud of her, given the fact that she now is leading a program in which she was trained. So one thing unique about our program here at McGaw is that we're all about really supporting our trainees and making sure our trainees achieve success in what they want to do. So Dr. Lindquist leads our program. We were a section of geriatrics, and she was the section director or leader. And more recently, given the fact that we've grown so strongly and that we've been productive, we became a division of Department of Medicine once again. So Dr. Lindquist leads a new division of geriatric medicine. And again, very proud of her, given particularly the fact that she trained with us. I am the second person in leadership in terms of the academic portion of the program, and I serve as the program director for the fellowship. Like Dr. Lindquist, I'm homegrown. I was trained here at McGaw and really asked and invited to stay on. I did that, and I too have somewhat grown up in the program, and I'm now the program director. I assumed that position in 2013, but the program in geriatric medicine here started in 1989. At the time the program started, we were having 2 fellows. We continued to have 2 fellows for several years. Then we went down to 1 fellow, and we're back now with a new complement of 2 fellows. We're approved by the ACGME to have 4 fellows. We now have 2 again, and the second fellow will be one that we'll be looking for in 2023. So the current fellow is only 1 fellow right now, and we will transition to 2 come 2023. Like Dr. Lindquist, I also hold a master's in public health and an MBA from Kellogg. I got my MD degree from Southern Illinois University here in Illinois and did my general surgery and internal medicine residencies at the University of Illinois. So I have homegrown here, and like Dr. Lindquist, we're both leading our respective areas within this very vibrant program at McGaw. I want to give a little backdrop because the purpose of this presentation really is not to boast about our program as much as we are proud of it, but really to kind of indicate to those who are listening and watching the urgency of really making sure that we have strong geriatric programs that will attract the best and brightest of our trainees coming out of internal medicine and family medicine residences. The older population is just thriving. Yes, there was a downswing during the COVID pandemic, but we're seeing our patients coming back, our residents coming back and coming out of isolation, reconnecting and actually thriving. We expect to have most people that you walk by on, say, Michigan Avenue in Chicago, and that's a really well-known avenue. It's where the Magnificent Mile is. It's where tourists come to see us. Every other person you will pass will be an older adult. I want to just get it to you why this is so important. The population is aging, and we need more of the best and brightest to take care of them. There are roughly 7,300 certified by that board certified geriatricians practice in the United States. And we project that we'll be needing a lot more because the population is aging. So by 2030, we need to have at least 30,000 geriatricians, and we're not close to that. But not only do we need to have 30,000 geriatricians, we need to have geriatricians who are really well trained, and by that I mean fellowship trained, who are board certified, which tells you as an older adult listening to this program, maybe by chance on Twitter, or your family and friends are listening, it really tells you when they're well trained and board certified that you're getting people who are coming with evidence-based practice. You will not find geriatricians who are that trained telling you as an older adult that it's just because of old age. Yes, there are aging changes, but we have answers that respectfully our colleagues who are not trained, fellowship trained and board certified will not have for you. So we predict 30,000 will be needed in 2030, and we need a lot more of our young people entering geriatric subspecialty practice. There are about maybe, it varies from time to time, about 130 something geriatric fellowship programs in the country. In Illinois, we have about 7 or so, and just not enough geriatricians to meet the need. I talked earlier about the history of our program. The inception was July the 1st, 1989. Our program has graduated a total of 66 fellows. Since its inception, 9 of them have graduated between 2013 and 2021. And I do highlight that because 2013 was when I assumed fellowship program directorship of the fellowship here at McGaw. I'm very proud of what we've done under my during my tenure, and we'll talk a little bit more about that going on. We have a 1-year compulsory training program. You have to be have completed a full medical residency, be it in internal medicine or family medicine, successfully. We expect you to have taken your board examination or plan to take it during the time that you're with us, because again, we believe in board certification. And we expect at the end of your fellowship that you will do your board certification or obtain that in geriatrics medicine. In fact, our fellowship program has it as mandatory. You must, you're literally signing a contract that you must take your geriatrics fellowship board examination at the conclusion, certainly within 1 year of concluding your fellowship training with us. I want to mention, before I move to the next slide, that while I am the program director, we have a fantastic program coordinator here named Tilly Moy, and she has been certainly with me the entire time that I've been program director. Program coordinators are important, and as you look at programs where you think you might want to train, if you're someone contemplating geriatrics, you should look at the program coordinators. Program coordinators should be prepared They should be knowledgeable. They should be able to communicate with you and will be responsive to you, because they're the first face or the first voices that you'll hear when you connect with a program. And we have fantastic coordinators here, and certainly Tilly Moy, who supports our program, is one of those coordinators. Here I'm showing you a kind of a photo that I literally stole from Dr. Lindquist. And this is one of our happy photos. It shows how we were feeling on the day that we were told that we had become actually a division again, and that Dr. Lindquist was going to be our division chief. So Dr. Lindquist is on the photo on the top, and we have, there I am to this side. Beside me is a very important person, and that's Dr. Anna Liggett. I want to pause and talk about Anna Liggett. Anna Liggett is a family medicine physician that we recruited from New York to our program. Anna came on board and was fantastic as a fellow. I mean, energetic, enthusiastic, certainly passionate about older adults, as we all are. And Anna concluded or finished her program at such a high level that we recruited Anna back. So something about McGaw Geriatrics that you need to know is that we are expanding and we're in a recruitment mode, and we try to recruit the best and brightest. Anna is also the Associate Program Director for the Fellowship Program. How many programs can tell you that? So there you have Dr. Lindquist, myself, and we have Anna Liggett. We're all three from the same training program, and we're here moving forward, really well trained as academic geriatricians to meet the needs of the best population on earth, the older adult. And beside Dr. Liggett, you'll find Dr. Sarah Bradley. Dr. Sarah Bradley serves as the clinical practice director here in our program. She is fantastic. And I really say that truly and enthusiastically, because she is really trying to get people connected to geriatrics early. And by that, I mean, she worked with first years. She's taking M1s, literally first year medical students, to nursing homes to get them connected with nursing homes so they can begin to understand. And it may not be the deepest understanding at that point, but she's lighting the fire under these young people so that they hopefully will develop a passion for geriatrics and an understanding that geriatric patients are the most complex patients on the face of the planet. They're more complex than cardiac patients. They're more complex than patients with lung disease. They're not just younger people getting older. Things change on the inside. They're what we call physiologic aging changes. The heart functions differently. The ventricle is more stiff. They will have a certain heart sound. And someone might say, oh, I think it's abnormal. But we know that S4 sound is not an abnormal sound. We expect it because we know that the ventricle, the lower left heart, is going to get stiff with aging. You know, they may have certain changes on lung performance, but we know that because of aging changes, and we know we can do something to facilitate a better function for them and to help them. We will not be saying, it's just old age and let's move on. But we know old age changes and how we can facilitate, fix, mitigate old age changes to support our patients. So again, I mean, I am really very proud to be a colleague of Dr. Sarah Bradley. Dr. Bradley also is the education leader in our center called the Pepper Center, and that's a center funded by the National Institute of Aging, whose purpose and goal is to get aging researchers enthusiastic, enthused, supported in research work that will be focused on older adults and that will help older adults thrive and do well into their very old age. So again, Dr. Bradley has been a fantastic addition to our staff. She did not, our faculty, she did not train with us, but it's almost as if she's trained with us. She's one of our adopted trainees and just really leading in her space in a very fantastic way. And beside her, the last person of the old crew, I'm calling it, on this photograph is Dr. Catherine O'Brien. And Dr. Catherine O'Brien is special to us because she also trained here. She was one of our fellows. Just amazing. She was so enthusiastic about our program that we connected with Catherine O'Brien at AGS before she even applied to the program. Dr. O'Brien is both a geriatrician and a palliative medicine physician. She's board certified in both areas, and she supports geriatrics and palliative medicine. And it makes a wonderful combination because a lot of our older adults are going through changes that need palliation. And Dr. O'Brien is able to support this portion of her practice. She serves in leadership also as the associate or assistant clinical practice director of our program. And the clinical practice directors really manage the day-to-day operations of our geriatrics clinic and make sure that things are running smoothly along with the manager within the clinic to support our older adults. Dr. O'Brien is one of my favorite physicians, and I think I'm a little biased here because I'm like the mother. I was part of her training, and I was her program director when she started. So we want to not leave out someone that's a little bit newer for us, and we're talking about Dr. Alexander Petrakis. Dr. Petrakis is our newest faculty member who graduated from a program at Vanderbilt University. And she has not only brought herself here, but she brought us a very, very tiny, a little future geriatrician. And by that, I mean, she just gave birth to her baby daughter. And so we got Dr. Petrakis, but we also got hopefully a future geriatrician in the process. Dr. Petrakis will support our home care program. And I should add that Dr. O'Brien developed that home care program, and Dr. Petrakis will be supporting that program going forward, along with Dwayne Dubchues, who is a nurse practitioner, exemplar nurse practitioner, who supports our home care program also. So I'm going to pause here to just talk about the 2 R's and the E. We recruit, we retain, beg your pardon, and we expand. We have recruited, and we're not gender biased. We just happen to be recruiting a lot of women. It's a wonderful thing, but we want to make sure people know that we would love to get men in our program. So, but we're recruited a lot of women, and we have been able to retain a lot of our own trainees. And Dr. Lindquist, our division chief, is expanding. She's looking for what the military would call a few good men and women to join us, because we are growing as a division. We are growing as a Department of Medicine, and we're growing as a medical education enterprise here at McGaw and at Northwestern University, Feinberg School of Medicine. And then I want to actually tell you a little bit about the recent fellowship graduates we've had. And recent is, you know, a variable term for me, because we're talking some people who were here in 2013, but I consider them recent. It seems like yesterday that Dr. Theresa Rowe was training in our program. Dr. Rowe is both an infectious disease physician and a geriatrician. And can you imagine being trained? She has left for the CDC full-time, but she retains an adjunct status with our department. Dr. Rowe, can you imagine being trained by an ID doctor who's also a geriatrician? I trained her, but then she came on as faculty and she was training and bringing this expertise in infectious disease to the process. Very helpful for our patients. Fantastic when you're dealing with nursing home patients who are prone to a lot of infections. Fantastic in helping us to identify sepsis, which kills our older adults if it's not caught early. Dr. Rowe has been instrumental in the education of our fellows, and as a fellow herself, she was fantastic. We have done projects together, we've presented together. So we have what I call an enterprise here of collaboration, not only across programs and within our program, but even closely with our fellows. And then ultimately when the fellows become attendings, with attendings. So I was collaborating with Dr. Rowe as a fellow. She has done fantastic work. The CDC is very lucky to have her, but we are still glad that she's connected to us in an adjunctive role. And then we have Dr. Jill Houded, who was a fellow after Dr. Rowe in 2014. And she is a homegrown fellow. She came out of our internal medicine residency here. And we went after her really because we knew she loved older adults. And we felt her personality and her intellect really was needed for our older patients. And we recruited Dr. Houded, who stayed on with us, and we would have asked her to join the group, but she moved to Cleveland Clinic with her husband, who's a cardiologist, and she's thriving there. Again, she also was very integral in buttressing the emergency room program called the JEDI program. As a fellow, she was so engaged with that program. And that's where the emergency room in a hospital is equipped, a portion of it is well equipped to support older adults. The beds, they've got real beds, not just gurneys. They've got, the lights are dimmed a little bit. The patients are assisted to go bathroom back and forth. They are seen and evaluated quickly. A social worker is available in case there are social issues that need to be addressed. They can bring physical and occupational therapy in while they're in the ED to support them. And I mention all this because I want you to know that when you come to a program like ours to get your training, you're being exposed to that kind of environment, one where you see the older adult being facilitated from the minute they enter the hospital, and often, regrettably, it's through the emergency room. So Dr. Houded is in the Cleveland area. I think she was moving on to Kansas. She served as an assistant professor. Dr. Rowe herself was an assistant professor. And so here we have two graduates who are assistant professors. When Dr. Houded got her first appointment at the VA on graduation, I wrote a letter to the VA and I told them, you have to take her on as an assistant professor because the level of her training at Northwestern really indicated and mandated that that should be done. And she was accepted at the assistant professor level. And then we've got Dr. Jennifer Fernandez, fantastic. We have always been about inclusiveness and diversity long before it became a buzzword. And we have Dr. Fernandez, who is Latina, of Cuban descent, who came to us from South Carolina and did really fantastically well in our program. Again, she also did collaboration and has publications because we are a collaborative research-oriented division, prior a section, now a division. And she is doing great work in South Carolina, working as a geriatrician. And then I talked about Catherine O'Brien to some extent when I mentioned the fact that she leads the GeriPal program and also supports the home care program, which she developed, actually started developing as a fellow. So Catherine O'Brien is just fantastic. She's done remarkable research work, showing interest in trainees, and I'll talk about the research work she's done afterwards. She has received numerous teaching awards. Most recently, she received the teaching award from the palliative medicine program. Before that, she received it from geriatrics. She's gotten at least 4 teaching awards since beginning her tenure as an attending. Kristen DeCarlo, fantastic. I tell you, if I can get someone to join geriatrics fellowship and become a geriatrician, but retain interest in cardiology, rheumatology, endocrinology, it's okay. All I'm asking, be board certified in your geriatrics and go out there and focus on older adults. And that's what Dr. Kristen DeCarlo is doing. She's just fantastic. She came to us from New York University, did her fellowship with us, and then Dr. DeCarlo did a second fellowship in endocrinology. And now she serves as the Associate Program Director for the Endocrinology Fellowship at the University of Illinois here in Chicago. And her focus is older adults. She's not straight from that passion that she's had for geriatrics. Her work is focused on diabetes in older adults and hypertension in older adults. She also has interest in bone health and osteoporosis. And so we have an endocrinologist who is what we'll call a geriatric endocrinologist, who has not left her passion or forsaken geriatrics. And moving on, we've got Dr. Alicia Gupta. Dr. Alicia Gupta has passion for geriatrics, but she also has passion for rheumatology. And we're beginning to learn that maybe it's time that we start getting people who have interest in other subspecialties into geriatrics, because even in pediatrics, having a geriatrics fellowship can be very, very helpful. I know it will be hard if you're a pediatrician to go into geriatrics, because you need to be either from internal medicine or from family medicine. But I'm making a point of how important geriatrics is. So many of my pediatrics colleagues tell me that they have patients, little ones, who are being taken care of by grandparents. And it's a common theme across the country, as young mothers struggle, or for all kinds of reasons are not able to really care, or have to go to work and primarily leave the care of their children in the hands of grandparents. And it's good for even that person who's a pediatrician to have some knowledge. At least they won't get the fellowship training, but have some knowledge, because they'll need to know how to integrate geriatrics into the care of their patients. Because if that grandmother doesn't do well, who's over 65, then the children won't do as well. So sometimes I find myself literally helping family members of patients who come to see me, where the family member is younger. The patient, of course, is geriatric age, maybe in their 80s, 90s. And I want to make sure that that caregiver is doing well, because I care about them, but also because selfishly, I know if they don't do well, my patient population won't do well. So Dr. Gupta did her fellowship with us, and then she was accepted into fellowship at Emory University and completed her fellowship at Emory successfully. Now she's a fully fledged geriatric rheumatologist working in Tennessee, and expect to be joining one of the academic universities centers there as an instructor or an assistant professor in the near future. She has not forgotten how important academic geriatrics is, and is looking forward to doing it on a broader scale, teaching within those institutions or that institution to which she might be accepted. I spoke about Dr. Leggett. Have to admit, one of my favorite fellows of all time. Dr. Leggett has done us proud. She is fearless. Dr. Leggett supports our nursing home programs on the North Shore. And with us getting 2 fellows coming on board, we expect one of our fellows will spend a lot of time with Dr. Leggett. She's an excellent teacher. She is enthusiastic about the program. She's very knowledgeable about nursing home patients, and will be a great teacher and mentor to that next fellow who's coming on board. And then we've got Dr. Ukabam, who is actually an assistant professor at UConn now, having been granted that designation recently. She is up in Connecticut working with older adults as a geriatrician, and planning to start doing academic medicine in the near future. Engaging, I should say, in academic medicine in the near future. So here we have, and this is just from 2013. Remember, the fellowship started in 1989. We've got a lot of people out there doing great things. Some are heading critical care units as critical care geriatricians. There are at least 2 of them. I have about 4 geriatric oncologists out there, because at one point we had a combined geriatric oncology program here at Feinberg, at McGaw Medical Center. And I'm proud of the work that my geriatric oncology trainees are doing in Las Vegas, in Wisconsin, and elsewhere. Just very proud. So this, again, just a small sample. Moving along, I just want to give shout out to my newest graduate. And you can see how happy she is, but a little sad that she's left us, but she's got this wonderful, warm personality. And that's Dr. Jennifer Delgado. She has been an amazing ambassador for us. I think she was one of our, what we call secret weapons. I think she can recruit anyone. Dr. Delgado is fantastic. She's originally from Peru, came to us from Cleveland Clinic, where she served as chief resident, and came here with fire under her belly, and has, we have an arrangement with the collaboration with the ACGME, which I'll talk about in a minute. But she really jumped in. She was just enthusiastic and just turned on, and looking for data, and looking at what she could do to add to the body of knowledge in medical education as it pertains to trainees. And she worked with Dr. Hugh, one of our surgeons here at Northwestern, was given access to the data, and got collaboration with Dr. Andrew Hugh, who's in the photo with her, who is a physician scientist, who is really engaged in really serious surgical research. And they put their heads together, and they have done fantastic work. They've presented their work at national surgical meetings. The work also at the Louis Landsberg Research Day here was accepted for presentation at Feinberg, and their paper has been accepted to JAMA Surgery. Dr. Delgado and Dr. Hugh are serving as co-first authors on this paper, and Dr. Hugh, myself, and other surgical researchers are also co-authors on the paper. But just fantastic. JAMA is a well-known publication, as you know, and they literally were only expected to make minor revisions to that paper. I just kind of tell you how much I'm thrilled with these two young people, Dr. Delgado and Dr. Andrew Hugh. Dr. Delgado has gone on to practice in New Mexico, and we hope that we can get her back here in a couple of years to join us. And we expect to continue collaborations. She and I are writing a book chapter that's actually due today. And so we will continue our collaborations going forward. And what's these collaborations, and what is this collaboration? So you saw the collaboration between Dr. Delgado and Dr. Hugh. I mean, crossing geriatrics and surgery. Who would have thought? Fantastic to look at medical education topic. And here we are going to just focus for the remainder of the time on more so on the collaborations with the ACGME, the Accreditation Council for Graduate Medical Education, the body that accredits all of these programs, including our programs and the programs of our cousin and sister geriatric programs out there. And we have been working with senior scholars in medical education, and it's been a fantastic journey. We have been with them over about maybe 7 years or so. The senior scholars are noted here, Dr. Joan Schwartzberg, one of the first, and I think might be the first woman medical student at Feinberg, who also was heading the AMA, a section of the AMA at one point, who started the first home care program within the United States, and who was invited by the White House to join the Council on Aging by the president. And so we're talking senior scholars with fire under their bellies and with firepower in terms of their journey and their accomplishments. Then we have Dr. Paul Rocky, well known again. Dr. Paul Rocky is a physician trained who has been just exceptional in terms of thinking outside the box. He has been instrumental in working with Dr. Schwartzberg with our fellows to kind of help them to come up with the question and to hone the ideas and to also work with the data in terms of medical education research. And then the late Dr. DeWitt Baldwin, who I miss and will always miss. He died at age 99. His memory was as sharp as a tack. And we lost him, and I'm sure COVID might have played a little role in that. But Dr. DeWitt Baldwin is considered the father of interprofessional education. He believes, like I do, he believes, like I wanted to say, that our deans do, definitely the Dean of Medical Education, that we need to work together, that we need to train together where it's possible. So I'm talking about physicians working with mid-level providers, with nurses, training together through the training programs so that we can bring to bear all of our expertise on patient education and patient care. And it's something that we have been doing at Northwestern, stronger in some areas than in others. But Dr. DeWitt Baldwin started this process years ago. He's highly regarded. There's a lecture called the Baldwin Lecture named after him that is annually presented annually at the ACGME, where people are invited to speak, to be a Baldwin lecturer. I'm looking forward to that starting again now that the COVID pandemic has kind of eased off such that we're going to meet in person, which we haven't done in about 3 years. So Dr. Baldwin is really missed because he could always bring to the table historical concepts and bring some old research that he had done and apply to new questions that we were posing at the table. Dr. Lauren Poulin is newer for us. She came from the University of Chicago to the ACGME. She's fantastic in her knowledge, in her ability to kind of translate research, both qualitative and quantitative, in such a way that it makes sense. We have a paper with her that's been submitted to Journal of Graduate Medical Education, I believe, and we are hoping that that will be accepted. And that's the work that she did with Dr. Judith Ukabam, one of our graduates, and we're hoping that will be published. And then we have got Mr. Nicholas Yagmore. I have to mention him because he's a data gentleman. He's a brilliant gentleman who really helps us to step back and look at raw data and understand what the data means in terms of the statistics, clean up that data and make the data make sense. And that has been instrumental as our fellows have gone through all their research projects in medical education with the senior scholars. So the senior scholars have acted like mentors and sponsors for every fellow that we had over the years with them. They've gone on to present at major meetings in education through the auspices of these senior scholars. They have been just fantastic. And through them, I myself have learned a lot. This is a sample of publications. We don't have, of course, every publication here, but I put the publications that showed the names of former fellows. You can see Dr. Rowe's name at the first one in bold. I forgot to bold Dr. Hudet's. And so you can see the variety of things, research projects on which, beg your pardon, our fellows have worked. Looking at emergency room risk, looking at, donor transplantations in older adults, certainly looking at urinary tract infections as Dr. Rowe did. She's an expert in that area of how to manage urinary tract infections in older adults in the community and particularly in nursing homes. Kind of looking at frailty, which is a big thing now. We're looking at frailty in the area of cancer, in the area of gynae oncology, in so many areas, and looking at frailty as Dr. Hudet and her husband and others did as it pertains to TAVR, the procedure done for patients with aortic stenosis to help them to live full lives. And it's in older adults that you're seeing those procedures done. And as you look down, you can just see on your own, looking at cancer, Dr. O'Brien and I did this paper together. Diabetes, you can see Dr. DeCarlo. I told you about the fact that diabetes in older adults is one of her passions, as is hypertension and so on. We're moving down, you can see what we have done. Dr. Gupta did work looking at lupus and the treatment with hydroxychloroquine in older adults with lupus, because one thing we need to remember is that there are two options. And I don't mean to be macabre, but we die or we get old. And I want to live to be 100. Once I've got my cognition intact, it's okay, I will take the disability, the physical disability, but I want to see what this world is going to look like when I'm 100. And so the options are only two that we have. And if we want to live a good quality of life and age healthily, we do need the support of geriatricians. And then Dr. Liggett, Dr. O'Brien, and Dr. Lindquist together have been looking at, this concept of how do we use these new devices, the mini Google Mini, and other voice-assisted devices to support our patients. Right now, my current fellow, Dr. Arsimran Singh, who came to us from California and from the University of Illinois, is looking at patient portals. We're talking about patient portals, but what do patient portals mean for older adults? If I ring my doctor right now, I'm going to get a message that says, maybe you want to go online. This is the link. You can go to this link and get your appointment and all that. So increasingly, we're being pushed away from our doctors. We're moving away rather than towards. And I understand. And I have nothing against technology. I embrace it as well as I can. But technology must consider who's going to use it. Those of us who are leading technological advances must think about older adults. Think of, can they hear the technologies that are available? Can they see? How are you presenting them? And what are the consequences if there are barriers to use of these portals, but the portals are still just shoved on older adults? Nobody, I think, invites them for let's have a focus group and ask older adults what can be done before a technology is launched. It's just launched. And so it's really wonderful to see Dr. O'Brien with mentorship from Dr. Lindquist, really looking at these kinds of devices and what we can do to make sure technology is truly a support and a benefit to older adults rather than an encumbrance going forward. And so that's a little bit of the work. And then in terms of the research projects that our fellows have done, I just want to touch on them a little bit because we do have a little time, and then maybe stop in case someone needs to send questions. And I don't know if that our format allows it, but certainly feel free to email. We'll give you my email address at the end. So these are some education projects that our fellows have done. One fellow, Dr. Delgado, looked at national evaluation of mistreatment and wellness amongst international medical graduates in general surgery residency training. And she did this with Dr. Andrew Hugh, and this is the paper that's going to be published in JAMA Surgery. Another paper looked at culture and experiences surrounding child rearing and pregnancy amongst residents and fellows enrolled in an ACGME accredited program or programs. So basically, we know that there are challenges. We talk about work-life balance and well-being and wellness. And I love Northwestern because up front and center on our medical school website is wellness. Wellness is a thread that runs through everything that we do. And we are not giving lip service to this. We truly are making great efforts to make sure that we keep our trainees well. And one concern that we face are really faced by women who are pregnant. Sometimes there's resentment when a woman is pregnant in training. And it doesn't mean that our co-residents or fellows are being mean per se. People are wondering, there's a lot of work. Will I have to take on all that work? What's going to happen? But it shouldn't be that way. We need to and we have actually made some changes since this research was done, looking at what programs need to do to make sure that fellows and residents are not put in this position of worrying about getting pregnant at a time. Many of them are in their 30s, their childbearing years are beginning to fade away. But now is the time that they can have a child. And so we need to make sure that programs are supporting, and the ACGME, in fairness to them, is looking at this data and really tasking programs to really make sure that that pregnant trainee is supported and it's given enough time to bond with her child before she comes back to continue her work. and is not punished. In some programs, there's punishment, and trainees sometimes are not allowed to graduate on time. They're under the table told you have to use up your holiday time if you want to graduate on time. And so, can you imagine being a woman pregnant and choosing between, oh my God, or wanting to get pregnant? I want to get pregnant before I have no eggs that are viable left, and but I want to finish my program on time. The next one was finding their voice, speaking up and speaking out. And this was a study that was done by Dr. Catherine O'Brien. It considered pregnancy and other things, but it was really about what happens when trainees speak out. What happens when trainees say that a program has deficiencies that need to be addressed? Are trainees being forced to say positive things about programs? What can we do? And we know that it's happening because in addition to the multiple choice, the checkbox questions, we do have an option where we ask for feedback from trainees, and many trainees are filling out that portion of the surveys. And so we know these things are happening, and it's what can we do? And of course, certainly every time we do a paper, present a paper, publish a paper, we know that medical educators are reading these papers, and we're hoping that certainly with the assistance of the ACGME that we can see good change coming. And then the last two, burnout in graduate medical education. This was a cluster analysis approach that was done by Dr. Kristen DeCarlo. This was her project. And looking at the concept of burnout and wellness, the so-called exhaustion that our fellows and residents sometimes feel. Things have really improved since I was a resident and since I was a fellow. Fellowship wasn't that bad. Residency was hard because I did 2 residencies, and they were rough at times. And I never thought about exhaustion. I was always exhausted. I'm sure I was always burned out, but it was like everybody did it. And so you just went through it, and they said, suck it up. And so you did. But now we know that you can't do that. That's just wrong. And we have had the cases from New York, the old cases that really have brought about changing work hours, work rules. And again, I want to really commend my institution because they are vigilant about work rules and about trainee burnout and trainee wellness. So again, if you're looking for a program, you want to look for a program that really takes this into consideration and puts in place psychologists, counselors, time off, time out, and have program directors and really monitor program directors to make sure that you're not being used as a supplement to your an attending who's not available. Suddenly you're taking their slot. That's not what you're there for. If you're a fellow in geriatrics, you're a junior faculty. You're there for education, research, and clinical care. You're not there to do scut work and to be a fill-in for attendings who are not available. That's not your job. And we have this edict coming straight down from Dean Nielsen, our dean of the medical school, that we want trainees to really be focused on education and learning. Yes, you'll take care of patients, it's important, but not in the context of being, the sweat hogs that you see working in some of these factories, clothing factories in certain countries, and maybe in some big cities like New York or San Francisco. And the final one was how gender and visa status impact internal medicine residents' well-being. And this one, Dr. Gupta, our rheumatologic geriatrician, was looking at, does being a woman, do you accept that this is your lot? And does being a foreign medical graduate makes you feel that you have no say, that you have to take on certain things, and so is your well-being compromised because you feel that you might be at risk of losing your spot or at risk of not getting a good evaluation at the end if you want to move on to another fellowship program? Those kinds of things. Are you being kind of shut down because of visa status and because of gender? And so those are some of the projects that we have done and we have presented, and we feel that we have contributed well to the body of knowledge. I'm wrapping up now just to point out that our program, we talked about collaboration. We have the Meslem Center for Cognitive Neurology and Alzheimer's disease. We work closely with people in that center, and we work closely with the Postosnak, I hope I'm pronouncing it correctly, Potosnak, I think, Longevity Institute. I'm going to say the Longevity Institute. Dr. Lindquist leads a geriatric agenda within the Longevity Institute, which is run by our department chair, Dr. Douglas Vaughn, doing great work, both basic science and translational work, and very important in terms of making sure we make that connection between cognitive aging, between longevity and the genes that might be affecting longevity. Dr. Vaughn does a lot of studies looking at the Amish people, looking at PA1, just to kind of understand why some people do well and others don't. And then we have the Pepper Center that I mentioned before, where Dr. Sarah Bradley leads the education core, which I said was just wonderful. Dr. Bradley is really committed to medical education and actually serves as the chair of the curriculum committee within the medical school. So we're talking about how do we do basic science research in aging? How do we look at cognitive aging and Alzheimer's, which is such an important thing more than ever as more and more people are being diagnosed. It could be that we're seeing more cases because people are better at diagnosing early. So look as if we have more a greater incidence. That being said, we do know a lot of people suffer from cognitive decline, and it's not a natural part of aging. Let me get this chance to use my platform and say it's not a natural part of aging. So working with that center through our trainees, rotating through that and doing collaborative work. In fact, we had a faculty member, Dr. Fernanda Haito, who actually was embedded in that center. So that's what real collaboration looks like. And then of course the Pepper Center, it's a new child on the block, NIH funded. There are not many Pepper Centers across the country. So you come to us, you're coming to a vibrant institution with this kind of collaboration, trans, department, trans division, trans center collaborations. You can't beat that. So in closing, I hope you got an understanding of what McGaw Geriatrics is about. It's bigger than I can even begin to express. I only gave you a snippet of it as it pertains even to the fellowship. You can go to our website to find out more about geriatrics in general, to learn more about the research of our division chief, Dr. Lee Lindquist. Fantastic work on planning your lifespan. You can go to the work that's been done by Dr. Bradley in medical education. You can go to the work that's been done by Dr. O'Brien as it pertains to looking at new technologies and how they play a role in aging. The work of Dr. Leggett as it pertains to nursing homes and generally long-term care, which is so important as the population ages. What does she do? What is she doing? How does she do it? Would be a great place to come and train to find that out. And I think I might be leaving out our nurse practitioner who's been amazing. You can find words about him, Mr. Dwayne Dupches, on our website. He's well known, has been featured on the news a lot about his passion for older adults and the home care program. So I'll be signing off shortly. Thanks for really listening. Those who are watching, thanks for watching. And we hope that we have been able to tell you why we're the unique program that you as an internal medicine or family medicine resident should be looking for training in. Thank you so much.